In this video, we are going to discuss about cardiac cycle. Contractions of the heart occur in a rhythm and are regulated by impulses that normally begin at the sinoatrial node, the heart's pacemaker. The impulses are conducted from there throughout the heart. Impulses from the autonomic nervous system affect the SN node and alter its firing rate to meet the body's needs. The pumping action of the heart is accomplished by the rhythmic relaxation and contraction of the muscular walls of its two top chambers, atria, and two bottom chambers, ventricles. What is cardiac cycle? Cardiac cycle is a series of pressure changes that take place within the heart. These pressure changes result in the movement of blood through different chambers of the heart and the body as a whole. These pressure changes originate as conductive electrochemical changes within the myocardium that results in the contraction of cardiac muscles. Whilst within the heart direct blood movement, which leads to organized propulsion of blood to the next chamber. There are four phases of cardiac cycle happen in the following order: atrial systole, atrial diastole, ventricular systole, ventricular diastole. First is atrial systole. After the SN node fires or sends signals, the atria depolarize and contract together, creating decreased volume and higher pressure in the atria than in the ventricle. The increased pressure pushes blood through the atrioventricular valves, that is, tricuspid and bicuspid valves, into the ventricle. It is important to note that the pressure of the blood due to the atria's contracting is what forces the AV valves to open. There are three steps to atrial systole as follows. As the atria contract, rising pressure pushes blood into the ventricles through the right and left atrioventricular valves. As atrial systole begins, the ventricles are filled to about 70% of their capacity because of passive blood flow at the end of the previous cardiac cycle. The atria contract and increasing atrial pressure provides the other 30% pushing blood through the AV valves. Therefore, the atrial systole basically fills up the ventricles to 100%. As atrial systole ends, the ventricles containing the maximum amount of blood they will hold in this cardiac cycle, which is known as the end-diastolic volume or EDV. This volume is about 130 ml or 4.4 ounces in a resting adult who is standing. Next is atrial diastole. The atria after the atrial systole repolarize and relax. The elastic fibers in the walls of the atria return the atria to shape, increasing the volume and decreasing the pressure in the atria. The blood pressure in the superior and inferior vena cava on the right side of the heart and the pulmonary veins on the left side of the heart is then greater than the pressure inside the atria, so blood pushes in from these vessels to fill the right and left atria. The semilunar valves close and the atrioventricular valves open. Blood from the pulmonary veins fill the left atrium. Blood from the vena cava are also filling the right atrium. The SN node sends signals again, triggering the atria to contract. The left atrium empties its content into the left ventricle. The mitral valves prevents the oxygenated blood from flowing back into the left atrium. The right atrium empties its content into the right ventricle. The tricuspid valve prevents the deoxygenated blood from flowing back into the right atrium. Next is ventricular systole. Early in ventricular systole, the ventricles contract, but blood flow has not occurred. The pressures are not yet enough to force the semilunar valves to open or to push blood into the pulmonary or aortic trunks. At this time, the ventricles contract isometrically, generating tension and increased pressure, yet blood does not flow out. This is called isovolumetric contraction, in which all heart valves are closed. The ventricular volume does not change, but ventricular pressure is increasing. When ventricular pressure exceeds the pressure in the arterial trunks, the semilunar valves open. Blood flows into the pulmonary and aortic trunks, which is the beginning of ventricular ejection. The ventricles then contract isotonically, meaning their muscle cells shorten and there is a near constant production of tension. When a peak is reached, ventricular pressure gradually reduces near the end of ventricular systole. The right ventricle also experiences isovolumetric contraction and ventricular ejection. Yet, pressure in the right ventricle and pulmonary trunk are significantly lower. The amount of blood ejected by each ventricle during contraction, that is 70 to 80 ml of blood, is the stroke volume of the heart. At rest, this is about 60% of the end-diastolic volume. This percentage is called the ejection fraction and is varied based on the different demands placed on the heart. As ventricular systole is ending, pressures in the ventricles quickly fall. Blood in the aorta and pulmonary trunk begin to flow back to the ventricles, closing the semilunar valves. When backflow starts, pressure reduces in the aorta. Once the semilunar valves are closed, pressure increases again and the elastic walls of the arteries recoil. Blood remaining in the ventricle when its semilunar valve is closed is called the end systolic volume or ESV. At rest, this volume is 50 ml, which is about 40% of the end diastolic volume. Once the conduction system has carried the electrical impulses from the AV node to the Purkinje fibers, the ventricles depolarize and contract together. Pressures in the ventricles rise to become greater than the atrial pressures, and the AV valves are forced to close. Papillary muscles also contract, pulling on the tendinous cords, chordae tendineae, to ensure that the AV valves stay closed and do not swing open toward the atria. This prevents the backflow of blood to the atria. Contraction of the ventricles decreases the volume and increases the pressure inside the ventricles. As a result, blood is pushed through the pulmonary and aortic valves into the pulmonary trunk and aorta respectively. The deoxygenated blood is pumped into the pulmonary artery. The pulmonary valve prevents the blood from flowing back into the right ventricle. The pulmonary artery carries the blood to the lungs for gas exchange. The oxygenated blood returns to the left atrium by the pulmonary veins. Oxygenated blood is pumped into the aorta. The aortic valve prevents the oxygenated blood from flowing back into the left ventricle. The aorta branches out to provide oxygenated blood to all parts of the body. The oxygen-depleted blood is returned to the heart via the vena cava. Next is ventricular diastole. The ventricles then repolarize and relax. The elastic fibers in the ventricle walls return the ventricles to shape, increasing the volume and decreasing the pressures in the ventricles. The pressure inside the now full atria is greater than that inside the relaxed ventricles. So blood moves through the AV valves from the atria to the ventricle. The atria are not contracting in this phase. Blood is passively moving from the atria to the ventricle due to the difference in pressure. The pressure is also greater in the pulmonary trunk and aorta than inside the ventricles, but blood is caught in the cup-shaped semilunar pulmonary and aortic valves as it tries to return from these vessels to the ventricles. Once filled with blood, these valves are tightly closed to prevent backflow to the ventricles from the pulmonary trunk and aorta. Blood traveling passively from the atria to the ventricles in this phase reduces the pressure in the atria. So blood also moves passively from the vena cava and pulmonary veins to atria. All four chambers fill with blood during ventricular diastole. There are two steps in ventricular diastole. During this period, all heart valves are closed and the myocardium is relaxing. Ventricular pressure are still higher than that of the atria and blood cannot flow into the ventricles. This is called isovolumetric relaxation. Pressure in the ventricles drops quickly since elasticity of the heart's connective tissue and cardiac skeleton help the ventricles to re-expand toward resting dimensions. When ventricular pressure reduces to below atrial pressures, the AV valves are forced to open. Blood flows from the atria into the ventricles, meaning that all these chambers are in diastole. However, ventricular pressures continually reduce as the ventricles expand. Pressures in the ventricles are so much less than the pressure in the major veins that blood moves quickly through the relaxed atria, through the AV valves and into the ventricles. This is a passive mechanism and is the main method of ventricular filling. Before the cardiac cycle ends, the ventricles become almost 75% full. Overall, atrial systole does not contribute greatly to ventricular volume. This means that the people with severe atrial damage often survive because the blood can flow from atria to ventricles by pressure differences. However, damage to one or both ventricles can cause the heart to be unable to pump blood through the peripheral organs and tissues, because the ventricle need more pressure to pump blood to whole body. The damage to one or both ventricles are called heart failure.